All right, Dr. Barker, I think we should go ahead and begin. So we'll kick it off now, and welcome again to everyone. Thank you so much for joining our monthly Lunch and Learn series. I hope many of you are returning and that you've joined us in the past for this educational series. And if this is your first time, please know we offer this every month and the topics change. So hopefully it'll be a recurring educational opportunity for you. I'm Alex Huffman. I'm the Assistant Director of Support Services at the Cancer Center, and very pleased to introduce you to Dr. Kim Barker. Before I go into Dr. Barker's bio, I want to remind you of a few housekeeping things. This is being recorded, and that is for your future use. So you'll receive the recording by link to your emails probably Monday or Tuesday of next week. So you can look for that and you'll be able to go back and reference anything that you might have missed. We also really encourage you to put questions in the chat. And while Dr. Barker cannot provide medical advice on maybe a specific condition or situation that you're dealing with, we do want you to put questions in that we can generally answer and provide some information and education on. And if you do have more specific questions, we encourage you to talk to your clinic if you're treated here to see if that might warrant a referral to the physical medicine department. So with no further ado, I will introduce Dr. Barker and let her take it from here. Dr. Barker is an associate professor in our Department of Physical Medicine and Rehabilitation at UT Southwestern Medical Center. Dr. Barker received her medical training at Creighton University School of Medicine. If you are following the Final Four, March Madness, Creighton did advance last night, so great to have them in. Dr. Barker completed her residency at McGaw Medical Center of Northwestern University, Rehabilitation Institute of Chicago, now the Shirley Ryan Ability Lab. She served as the administrative chief resident. Dr. Barker is a member of several professional organizations, including the Association of Academic Physiatrists, and served on the PM&R Palliative Care Task Force. She is also a member of the American Academy of Physical Medicine and Rehabilitation and is currently the president of the Texas PM&R Society. She's also served as the PM&R Residency Program Director for seven years and currently is in the role of Associate Residency Program Director. She's delivered many presentations nationally and published several academic articles. Her research has focused on medical education as well as the rehabilitation needs of medically complex patients, including the cancer population and those who have undergone solid organ transplantation. So Dr. Barker, please feel free to share your slides, and thank you again for being with us.
All right, thank you everyone. Thanks for coming. I didn't send in my bio while I share this, hopefully. I also went to the University of New Mexico for college and they're playing today. So I am going to share my slides. Forgive me if I do not do this correctly, but hope, someone just mentioned to me if it looks okay. Looks okay? It looks like.
So we can see the presenter mode, Dr. Barker.
Presenter mode. Okay, so how do I switch? It did not, hold on a second. Let me start from the beginning. I apologize. I had practiced this before, and of course it didn't work, right?
No problem at all. Your Lobos are getting some love in the chat already.
All right, I'm going to start. Is it still presenter mode or is it the right way?
That's perfect. We have full screen now.
Perfect. Awesome. Okay. So thank you for joining. Hopefully this is helpful. It's mostly meant for patients. So if there's any of my friends that decided to join on, it's not going to be super medical, but hopefully it is helpful. I have been here at UT Southwestern since 2011, and I've had a clinic in the Cancer Center since I think 2012. So I've been doing this quite a while. It's definitely, cancer rehab has a huge place in my heart. The objectives today are to explain cancer rehabilitation to everyone if you're not familiar with it, and then just via cases, highlight how different things that we can help with during treatment or survivorship, and just kind of get questions started that way. So for people who don't know, physical medicine and rehab is a branch of medicine that aims to enhance and restore the functional ability and quality of life of patients with people that have physical or cognitive disabilities. It's a very I joke around with the med students. It's a very vague specialty that's broad, and that's actually what drew me to it because you can do a lot of different things. It's terrible for marketing purposes because you get confused because it is so broad. So I have colleagues from residency that do sports medicine and are the team physicians for the women's soccer team and for the Washington Wizards. But then I do something very, very different than that, right? And I see patients with cancer and who have cognitive and physical disabilities from that. And I have colleagues that treat people with traumatic brain injuries or amputations. So it's quite the gamut of things that we deal with. As you can kind of expect, cancer rehabilitation is just a subspecialty of PM&R, of physical medicine and rehab, and focusing on the needs, the specific needs of people who are going through cancer. So it's a multidisciplinary field in that a lot of what I do, I heavily utilize other people to get to that goal. And I actually forgot to put on the slide the most important part of the team, which is the patient, which is you, because what my goal is based on what your goal is, and trying to figure out how we can get you functioning better, and how we get to that goal. So that is my role as a cancer PM&R physician. I will prescribe medications, do certain procedures, send you to the right therapist or the right other specialist in order to try to reach that functional goal that you have. As I mentioned, I refer to a lot of therapists, so physical therapists, occupational therapists that do more things with the hands and upper extremities, and then speech and language pathologists who do more than speech, more than communication. They work a lot on cognition in case people have kind of chemo brain or a little bit fogginess. Also working on swallowing in case that's a problem with the cancer treatment. So a lot of speech and language pathologists do quite a bit of different things. I also heavily rely on my nursing staff to help communicate and answer questions with the patients. And then we also use a lot of social work too, in order to help get equipment that might be needed at home or any other resources that may be needed to help take care of yourself. A lot of times, I guess a lot of times there's a question of when to see someone like me or one of my colleagues. And the answer kind of what like PM&R, where it's broad and vague. The right time to see a cancer rehab doctor is kind of different for everyone, and it's any time. There's some people that see one of us at the initial diagnosis. There might be acute changes that have occurred because of the cancer that had led to the cancer diagnosis. Say weakness or some sort of numbness or tingling or some kind of symptom that led to the diagnosis. Or it's also to potentially address any other, what we call premorbid physical impairments. So say you have Parkinson's disease and then you got diagnosed with a type of cancer and we're really worried about your balance and being a fall risk. So addressing anything that might be going on as well to try to prevent any worsening of those impairments. We also see a lot of people during what we call surveillance and treatment. So if you have pain or other issues from the surgery that you may have had from cancer or the treatment, the chemotherapies, we kind of help along with that. A common thing is neuropathy, right, with chemotherapy. And so we address the burning and tingling pain and maybe any balance or weakness that comes from neuropathy. We also work on strengthening because a lot of the treatment can make you weak, and it also may make you feel sick, and you may not be getting out of bed quite as often as you usually do. And then you quickly lose your strength and your endurance during the treatment process for some people. And so it's helped to strengthening and build back up your endurance. We also, because we're looking at what I call functional health, we want to make sure that you guys are all doing the things that you want to do, going out into the community and seeing your friends if that's what you normally do, going and working if you can work, or planning on returning to work and making sure that you're able to do that when the time comes. So I kind of put promoting reentry to the community and vocational social roles and family roles. We are also helpful during the screen, kind of if you have, unfortunately, recurrence, and trying to help, again, kind of like the initial diagnosis, figure out what we can do to help prevent any further physical impairments if you have to go through treatment again. And then towards the end, if we're just doing palliative treatment, it does not mean that there's still not functional goals to achieve. We still believe that the quality of life and being able to do as much as possible for as long as possible is the goal for everyone. And so from there, I'm going to go into patient cases. I will put a disclaimer that I have 3 cases. The first 2 are just a kind of combination of a lot of people that I've known and taken care of over the years. So if things seem similar, if any of my patients are watching this, it's not specifically about you, but kind of similar cases, because I've seen a lot of people over the years. I will say the third case is actually a more specific patient from a long time ago, but it's one of the ones that it has really stood out in my career, and I truly enjoyed taking care of him. Okay, so the first case 1, a 47-year-old woman with breast cancer. She received neoadjuvant chemo, followed by bilateral mastectomy, and then had deep reconstruction. She's really been struggling with a lot of pain in her chest area and kind of abdomen from the surgery, as well as some lymphedema. And she also has some balance issues from a little bit of neuropathy from the chemotherapy. She's a flight attendant and she really misses working. She really enjoys flying and traveling to different places, really misses her coworkers. I have had a number of flight attendants, so I have really learned everything that flight attendants do and also the little nuances of the different airline companies. And so the things that we worked on is for this case, or that I would work on with this case, is that working on the pain. Making sure a lot of times after surgery, there's a lot of irritation to the nerves in your skin and your chest, and that causes quite a bit of pain. So providing the right type of medication to help with that nerve irritation can make a big difference, as well as doing a referral to lymphedema therapy to help getting rid of that lymphedema and learning how to take care of the lymphedema yourself down the line. A patient like this, I would also send to physical therapy to work on what I call scar tissue massage. After this kind of surgery, there's typically a lot of scar tissue and fibrosis that can also cause pain and tightness, and also make it harder to get rid of the lymphedema in your chest or the area that you had surgery. So those are the kind of things that I would recommend for this lady and that I did. And then also physical therapy to work on the balance. What I've learned taking care of flight attendants is that you're pushing the cart down the aisle, and if the plane is ascending or descending, you have to make sure that you can stop the cart. If there's turbulence, you don't want to be falling down when you're on the plane. And then you're also reaching overhead and helping passengers with their suitcases. So balance is a huge part of being a flight attendant. So working on that with the physical therapist. And with time, this kind of regimen, it's not going to happen overnight, but with time, after a few weeks to a couple of months, with this kind of regimen, I've had patients go back to work and being able to go back to being a flight attendant and flying cross country, overseas, doing international work. So that's the first case that I have. Second case, to kind of highlight different things that we can do. 62-year-old woman with prior thyroid cancer, and then she had head and neck cancer. So she had treatment for that and she had surgery and a lot of radiation, unfortunately, which has made her neck more stiff and has caused muscle spasms. The stiffness is constant, but it's not too terrible that it makes her take any medicine. However, she really likes reading, especially reading at night. And so it helps calm her down and helps get her in the mood to fall asleep. So she'll read in bed, but when she's looking down and doing certain movements, it causes the neck spasms to be a lot worse. She also will have intermittent neck spasms when she's yawning or sneezing, and just it kind of passes real quickly, but it's pretty painful. The longest one, the spasms are the most painful and the longest when she's reading, just because she's holding that position for quite a while. She doesn't really like taking medicine because it makes her drowsy. She's had a lot of medicines in the past and it just always gets drowsy. So she wants to try to avoid taking any pills if possible. But she likes to read and it helps her sleep. And if she's not able to read, then she kind of has to take more medicine to help her sleep. So what I would do for a patient like this is I, again, would send to physical therapy and kind of work on getting better range of motion of the neck and kind of stretching and working on that scar tissue after the surgery and the radiation and help get better range of motion. A lot of times some massage and doing that scar tissue massage will help with the spasms that happen after radiation or surgery. And so that can help with some of her pain as well. And teach her, it's real simple to teach a patient how to do the scar tissue massage and the massage on your own at home. So the patient goes and does physical therapy and notes a significant increase or improvement in her pain and spasms. However, they're still happening and it's still bothersome, especially with the reading. So I talked to her about doing botulinum toxin injections or Botox injections. We use it more than just wrinkles. The way Botox works, or any of the botulinum toxins, there's a lot of companies that make it, is it makes the muscle a little bit weaker. And by making it weaker in this situation, it helps decrease the spasms. And you just need a tiny bit of Botox or botulinum toxin, a little bit more than for wrinkles, but less than we use for other kind of conditions, and inject into certain muscles that are spasming in her case, not everywhere in the neck, but target certain muscles that are causing a lot of problems, and just do a tiny amount. And the patient, it doesn't work immediately, but after 1 week to a few weeks, there is an improvement, and the patient notes that she's able to read more comfortably without having spasms. You can repeat botulinum toxins every few months if needed. And so this patient decides that there's still a little bit more room to improve. And so we repeat the injections and keep up with her stretching and her massage program at home. And then after that second set of injections, she feels great and she's not having significant spasms and able to do everything that she wants to do. The third case I have, so this is the one that has a special place in my heart. A 60-year-old gentleman with metastatic melanoma to his spine and spinal cord. He is paraplegic, so he can't move his legs, and he's using a wheelchair. And he has been for a couple of years by the time I met him. He has difficulty with his bowel and bladder because of the spinal cord injury. And he has frequent urinary tract infections that require hospitalizations for the antibiotics. He ends up having to have IV antibiotics. He also has really bad constipation. His wife helps take care of him, and she is just kind of at her wit's end trying to figure out how to take care of him. She feels like it's her fault that he's getting these frequent urinary tract infections. She doesn't know how to, she feels like he gets constipated and then she gives him medicine, and then next thing you know, he's having diarrhea, and that is terrible, and she just feels lost. And so what I do is that I, along with my nursing staff, help make sure that she is taking care of his bladder correctly. She has to cath him because of the bladder issues. He's not able to urinate on his own, and so she does a temporary catheter in and out to help empty his bladder. The nurse helps. My nurse helps her make sure that she does it in a clean way so that she does not give him any urinary tract infections. We also work on timing to make sure that his bladder doesn't get too full. We also work on a bowel regimen to make sure that he's having consistent daily bowel movements, but also at times where it's convenient, because that's also an issue with people that have spinal cord injuries. You don't want to you don't want to be out and about, say, seeing your doctor or doing something in the community and have to have a bowel movement in public, because it's a bigger hassle. So if we can time the bowel movements to either in the morning or the afternoon, that also helps him and her get out of the house and do the things that they want to do. So we do all of those things and help teach the wife and the patient how to manage a lot of these symptoms from the spinal cord injury at home. We also work on making sure that he is getting in and out of his wheelchair okay, that they have enough equipment at home for a shower, the correct bedside commode or elevated toilet seat, and just other equipment at home to make sure that their life is easier. Let me see how I did this. Okay, so I have pictures of this. I keep seeing them throughout for the next few years, and his wheelchair is doing well. He can push his wheelchair, or what we call propel his wheelchair, on his own, but he's starting to get a little bit tired when he pushes it on his own for longer distances. And he has new grandbabies. He really wants to go out and go on a walk with his grandbabies. So we start talking about getting a power wheelchair so that he can push the stroller and drive his drive his power wheelchair so that he doesn't have to push his manual wheelchair and push the stroller. It's kind of hard to do both of those things. So I work on getting him a power wheelchair. And that opens up a ton of doors. They had just been kind of going shorter distances in the community just because he'd get tired of propelling his wheelchair, and then his wife would get tired pushing him too. So the power wheelchair allows them to start traveling again. And they go to New Orleans where they actually met and they used to live. And so they go back and they have a wonderful time. And when they come back, they talk about how they never thought they were actually going to be able to travel again. And getting this power wheelchair has allowed them to truly go back to the life that they were leading before he had the metastasis to his spine. And so they were super grateful for providing and helping to get the right durable medical equipment in order for them to be more functional and to live the quality of life that they wanted. And so again, that's what I feel like it was a lot of different things that he and his wife wanted, and that's why it just made me so happy. He was able to go. He did a camp every summer for with other people with disabilities, and brought their kids out and their families out to this camp, and just was able to just truly do everything that he was doing before. And so anyway, those are my cases. I'm happy to answer any questions. Actually, before I answer the questions, so we have a therapy gym at the Cancer Center. This is a picture of the therapy gym. And then myself and Dr. Fadu, Dr. Michael Fadu, are the two main cancer rehab doctors here at UT Southwestern. We both have clinic at the Cancer Center right next to where this gym is. We have physical therapy there, occupational therapy there, including lymphedema therapy. And we have speech and language pathologists. Nobody is at the Cancer Center, but then they're at some of the other sites at UT Southwestern. But I just wanted to show you a picture of the setup and of the lovely space. We're on the second floor, which is the main floor of the Cancer Center. I will stop my PowerPoint. Sorry, I hope I didn't talk too fast. Sometimes I do that when I do public speaking.
We have some great questions in the chat, Dr. Barker, so we'll get started there. The first question is, can you talk a little bit about how physical medicine and rehab may address appetite issues when patients after treatment lose desire to eat? We know that's often connected to how mobile we can be. How does that come into play for PM&R?
Yeah, that's a great question. So I look at it from a lot of different views. One of them is making sure that you're actually having regular bowel movements, because constipation can make you not feel like eating if you're backed up. So making sure you're having regular bowel movements. Making sure that you're more mobile and getting up and moving around, because if you're not utilizing that energy, your body may not think that it's hungry. And then I also, I didn't mention it in my talk, but I feel like PM&R, my field, is just very practical. So I do a lot of troubleshooting with my patients and trying to do little tricks. So I tell them if they're taking a supplement like Ensure, and you guys are unfortunately all taking lots of medicine through the day. If you can take your medicine with food, I say instead of taking it with water, take it with your Ensure. And then you're getting a few sips or a few gulps of your Ensure while you're taking your medicine, and getting a little extra nutrition that way, and sneaking it in as best you can. I feel like a lot of my patients, they get real full if they eat too much. And sometimes they get full if they drink the whole Ensure. And so if you're sipping on it throughout the day, then it helps kind of get the calories and the protein that you need without getting that full yucky feeling.
And I'll just add a plug for our dietitians. We do have a fantastic crew of dietitians here at the Cancer Center who would be another great resource for that. Great question here about, and you touched on this, adding in that scar tissue massage. Is that something that someone could just ask their current PT to help instruct them on? Should they go back to their doctor for more guidance and maybe another referral?
No, a lot of physical therapists can do it. You just have to be very specific with asking. And it is really easy to do. I mean, in the grand scheme of things, it's not difficult to, and you can also, if it's hard for you to manage it yourself, you can ask your loved one how to do it, to be taught how to do it. I tell my patients a lot that scar tissue is kind of like pizza dough. So your normal tissue is nice and parallel, and it's nice and flexible and stretchy, but your scar tissue is kind of laid down haphazardly. And so if you don't stretch it out, it kind of gets tighter and tighter with time. And so you just kind of have to constantly massage it, and kind of like pizza dough, you have to knead it out. And sometimes if you're not massaging it, it'll get tighter again, just like pizza dough. If you leave it on the counter and you go to get the pizza sauce and you take too long, that pizza dough has kind of gone tighter back into that ball. So it's just going to be, unfortunately, potentially a lifetime of massaging. But on the flip side, it's just fairly simple, and massage is not going to take you hours of your day at all. And that will help a lot with the scar tissue.
And Dr. Barker, if the massage does not seem to be helping, if this is a case of lifelong massage, what else might be included that could help impact that?
Sometimes some medicines will help a little bit with the scar tissue and making it looser. We can potentially do some injections or other procedures to help break up the scar tissue. It just kind of depends on the situation. I will say that a lot of times, if it's, I guess some of the scar tissue from radiation is a little bit more harder to break up, but a lot of the scar tissue from surgery is pretty pliable and easy. So it just depends on the patient and trying to do a whole bunch of different things to get the desired effect.
And here's another great question about the overlap between cancer rehabilitation and psychotherapy. How do you guys work with our amazing team of psychologists here?
Oh, we work, oh my gosh, they are a huge part of it. And it's correct. There's a lot of psychological issues with cancer and cancer treatment, and with trying to get back to your normal functioning, right? There's this kind of this sense of loss of the way that you used to be and how you are right now, and it takes an adjustment. There's also, I find a lot of uncertainty too when you're getting treatment, and even when you're finished with treatment, that fear of things coming back. And that I see a lot of it. I've seen it in my family as well, where aches and pains or normal side effects from treatment are seen as potential recurrence of the cancer. And so there's a lot of fear and unknown. So it's addressing those things and referring to psychotherapy or psychology or psychiatry as needed. Some of the medicine that we use, or that I use for neuropathy and for some other issues, also has some mood component too. And so if I think that it would be helpful for the patient to treat both of those things at once, I kind of suggest those medications a little bit more than others.
Okay, so you hit on the next topic of interest here, which is neuropathy, which is such a pervasive and difficult side effect from treatment. What do you suggest for neuropathy, and how is that handled from a physical medicine standpoint?
There's a lot of things. I tend to see people, once the neuropathy has started, and then it becomes a question of how is it impacting their life, because it's very different for everyone. For tingling, burning kind of pain that comes with neuropathy, there's a lot of medicines that can help with that. It won't cure or necessarily treat the neuropathy, but it's, if you think of it as a pain medicine, it will help with that neuropathic pain. That's what we call it. So that tingling, burning, pins and needles pain. That medicine sometimes helps when there's numbness, but it doesn't always help with the numbness. It doesn't hurt to try. But it's just, I'm not always as optimistic that it's going to make a huge difference. The other thing that I worry about with neuropathy is the balance, because I don't want anyone to fall. And as I joke around, but it's also true, I don't want anyone to fall and break a hip or, hit their head and have a bleed. So I really get nervous about people's balance and making sure that they're safe. Things that are easy to do, but it's also easier said than done. Exercise has been really shown to help chemoneuropathy. It helps decrease the symptoms, whether it's numbness or tingling or the balance issues. I say it's easier said than done because a lot of times people don't feel like getting up and walking or exercising, or they have those balance problems, right, that make them real nervous to walk or exercise because they may fall. And so a referral to physical therapy can also help with the balance and getting back into an exercise program. We have a really great Lisa Ross here at the Cancer Center, and then Dylan are really helpful with doing exercise programs for patients, but getting up and moving has been shown to help decrease the symptoms. It also keeps you strong and active. I also tell a lot of people that the nice thing, and I tell my residents this too, the nice thing about chemoneuropathy is when treatment's done, it usually gets better. Sometimes it goes away completely, but for the most part, it gets better. And that's the difference between diabetic neuropathy, which is the most common in America. Diabetic neuropathy will never get better, but the chemoneuropathy usually does. It just takes time. So it's figuring out all these medicines and other treatments that we can do to help pass the time until it gets better on its own.
And Dr. Barker, is neuropathy common for all chemotherapy treatments, or are there specific types of chemo that tend to cause neuropathy?
There are definitely specific types that cause more so than others, and even then, there's specific types that may cause more weakness than others. I try not to comment too much on that because the bigger picture is treating the cancer, and not being picky and choosy about which chemotherapy you get, but just knowing that myself, your oncologist, everyone on the team is going to try to help you if the neuropathy starts to develop, and we'll figure out the best game plan to prevent it from being really disabling.
And here's another good question for patients. How might patients know the difference between the pins and needles and the burning feeling, if that's neuropathy, or if that might be something dermatological?
Oh, that is a good question. A lot of times if it's dermatological, you'll see redness or a rash. Neuropathy, sometimes there's skin color changes, but not all the time. If it's dermatological, you'll definitely notice some changes in your skin. So that's an easy way to try to differentiate it. Obviously, ask your physician or your other healthcare provider if you're ever confused. And honestly, whenever you have any of these symptoms, you should let them know when you're at your visit too, and they can help diagnose it for you.
So we'll switch topics to lymphedema. Can you talk about how we treat lymphedema post prostate surgery and post breast cancer treatment?
It is unfortunately something that you are going to have to manage for quite a while, if not forever. But it doesn't mean that it's going to take up your life. We send our patients to lymphedema therapy, where they learn how to do a special type of massage to get rid of the fluid in their arm or their leg or wherever it happens to be. I kind of like to explain lymphedema as there are lanes down on the highway. So some of the lymph vessels in your arm or your leg are not working. So there's lanes down on the highway, and there's already traffic, and then the Cowboys game just ended, and so a whole bunch of extra traffic is out there. And so what lymphedema therapy does is it helps redirect traffic to where there's open lanes, and so you can decongest the limb, the arm or the leg that's swollen. And the lymphedema therapists that we have here are absolutely phenomenal, and they'll teach you how to do it on your own. They'll teach your loved one how to do it if you're not able to do it on your own. And we also do other long-term management, so compression garments to help get rid of some of the swelling, but also prevent the swelling from happening. Learning how to do wrapping, which sometimes is a little bit better than the compression garments, and then also figuring out if you might benefit from a pneumatic pump that helps pump out the fluid too. We also talk about making sure that your skin is good, because if you have lymphedema, you're at a little bit higher risk of having a skin infection or cellulitis. So making sure that your skin health is good, and also encouraging our lymphedema patients to exercise. Exercise has been shown to help get rid of lymphedema because when you're moving, your muscles are contracting and relaxing, and it helps pump that fluid out of the limb that's swollen. So doing all of these different things to help manage the lymphedema.
How different does the scar tissue massage look from lymphatic massage?
Oh, it is actually quite different. The lymphatic massage is a very light touch. So I've had some patients say they're like, just the lymphedema therapist is just like tapping me with her fingers. I don't know what's going on, but it's a very different one than the scar tissue massage. So it doesn't. It's very. It's different. It's easy to learn both of those. It's just different ways of getting to the problem.
Okay, so now we're going to veer into bone health. Lots of questions about osteoporosis. How does chemo contribute to osteoporosis? Do things like Neulasta also contribute? Can you talk a little bit about that?
Sorry, my camera's starting to fall. I knew this was going to happen. I can definitely, a lot of the chemotherapies, a lot of times, not everyone, but a lot of people will be on steroids as well with the chemotherapy. That will help, that will not help, but that will make your bone health worse and cause demineralization. The oncologists in our team are really great at sending people to the mineral metabolism clinic, which helps with osteopenia and osteoporosis, and making sure those that need to take medications for that are on medications. And then from my standpoint, what I kind of focus on is more how exercise and strength training can help prevent osteopenia and osteoporosis, and focusing on different ways to get people up and mobile and how to troubleshoot. I say troubleshoot because a lot of people are not. I'm not a big fan of exercise myself, but it's really that weight training and strength training that helps keep bone health, keeps your bones healthy and strong, and makes the little cells in your bone keep building more bone. So if for instance, I do have some people that love to do strength training and do the weights, and that's wonderful. But I have a lot of people who just kind of like walking around the neighborhood, chatting with their spouse or their friends when they're walking. And so figuring out how to add some weights into their exercise regimen. So people who like to walk, I'll tell them to either carry a couple of water bottles with them for just 1 or 2 pounds, or get those wrist or ankle weights that they can put on while they're walking, and just do things that they would naturally do or they're more inclined to do, and just add the strengthening component to it.
And I think another really difficult side effect is joint pain that we see from chemotherapy. How does PM&R approach joint pain?
It's a combination of lots of things. So medications, and trying to figure out which medications are most helpful for the joint pain, as well as which medications you can take. A lot of times ibuprofen or NSAIDs are really helpful for joint pain, but you're not allowed to be taking it. So then you kind of like are stuck and trying to figure out what to do. There are a lot of topical NSAID, so Voltaren is the brand name. The generic name is diclofenac gel. So it's a topical NSAID that a lot of the oncologists are totally okay with you using. That will help with joint pain. It helps more with like hands or elbows, shoulders, deeper joints like your hip. It's a little bit harder because it doesn't penetrate through the skin quite as deep. But those kind of medications, honestly, sometimes Tylenol helps. Some of the nerve pain medications that we use will also help with joint pain. So we'll try to figure that out as well. Sometimes we have to use opioid pain medicines to make the pain tolerable. So just kind of figuring out where the pain is and what works for the patient. Again, something that's easier said than done, but water aerobics or water therapy is actually wonderful for joint pain. And if you can get a pool that is what's called a therapy pool, it's a little bit warmer than a regular pool. And so it's nice and it's warm. It makes your muscles and your joints feel better. You're buoyant in the water, so your joints aren't pounding against each other quite as much. And you get the aerobic exercise. You also get the strengthening exercise in the water because of the resistance of the water. So I am a huge fan of water aerobics. It is, I will admit, a hard sell to a lot of patients who don't want to be wearing a swimsuit. And I tell them that not everyone wears a swimsuit in the pool anymore. There's a lot of people that just wear shorts and a t-shirt. And it's even a harder sell for a lot of the guys. But that is one of the best exercises. And it really has been shown that exercise and movement helps decrease the joint pain, but it's just hard to get over that hump because when you first start moving and exercising, it makes the joint pain worse. And I totally understand that. So it's just trying to figure out the pain medicine to allow you to move more and then do the exercise and then the pain should get better, hopefully, and keep working and figuring out what medications, what exercise is best and gets you the best relief without causing more pain.
Is it ever too late to benefit from physical medicine, scar tissue massage, neuropathy treatments?
I don't think so. I think any of it can be addressed at any time. I've seen people with scar tissue from radiation from the 80s. And so we still have things to work on. I've seen people with neuropathy from ages ago as well, and they're still, I was thinking of one particular patient. I will be honest, I wasn't sure if I was going to make much of a difference. I knew I could make a difference with his balance and his walking, but I wasn't sure if I was going to make much of a difference with his pain. But he just hadn't tried the right combination of pain medications for his neuropathy. And so we were able to get that to through just questions and answers, figure out what might work for him. So I don't think it's ever too late. It's always worth a try, in my mind, right?
Exactly. And our next questions are kind of in that line of other things to try. So I'll kind of go step by step here. Rebounders, are those helpful for lymphedema? And I'm not really familiar with
I don't know what rebounders are. I apologize.
Okay.
And I probably am just, once it's explained, I probably would be like, oh, duh. But I don't know what that is right now.
Okay, so we'll ask the person who put that question in if you could provide some more detail. We'll come back to it. Here's one I've seen and heard more folks using lately: whole body vibration. How might that be helpful with lymphedema?
So there's more and more studies looking at that. I will say, in theory, the whole body vibration kind of helps loosen the fluid up, and so that it can be so that traffic can be redirected a little bit easier. I have some patients that absolutely love it, and I have some patients that don't notice a big difference. I will say that most of the people that don't notice a big difference tend to be my breast cancer patients that have upper extremity lymphedema, and the people that tend to like it more are the lower extremity lymphedema. I also have people that don't have cancer that see me for their lymphedema, and they kind of have more whole body lymphedema. They also benefit from the vibration more so than the upper extremity.
Here's another one for neuropathy, laser therapy. Do you see that laser therapy could improve, especially neuropathy or diabetic nerve damage?
I'm hopeful that it will be. There's not a ton of great studies out there, but there's actually some more promising studies in amputee patients who have phantom limb pain, which is a different type of nerve pain. And so hopefully as time goes on, there'll be better evidence that the laser therapy is helpful, and that there will be more places that do it. There's not a ton of, especially in the Metroplex, not a ton of physical therapy or therapy locations that do the laser therapy, and often they're really expensive. And there's just other roadblocks to getting care at those facilities. So hopefully that changes as there's better evidence and insurance is more willing to pay for it.
Okay, we got some clarification. A rebounder is a mini version of a trampoline. So do you see that a trampoline-based exercise may help?
I'm sorry, and was it helping? I forgot what it's supposed to be used for. Helping
lymphedema.
Lymphedema. Actually, so now that I know that, I have had somebody ask me that. I personally haven't had anybody tell me that they've had benefit from it. I think it is in the same idea as the whole body vibration. So when you're bouncing, you have that little bit of vibration. It probably would not be as a the vibration from the trampoline from the rebounder would be different than the machine, and I'm not positive that it would be as helpful. It sounds fun, also dangerous if you fall off. But I feel like it's one of those things that honestly, if you were in my clinic, I would tell you if you have access to it, you should try it and see if you like it. But I don't know if you necessarily want to go and pay money for it.
There was another question about weighted vests. Is that something that you recommend for patients who are at a certain exercise level?
I would, if it's not too heavy and if you're trying to build more muscle strength and it'll also help your bone health, weighted vest would be a great idea. Some people, there's different types of vests too that help work on your posture. And so there's more weight in the back than in the front so that you sit more upright as I slouch down. Um, so those can also be really helpful, especially in, well, I call it the American posture, where you kind of slump forward over your computer and your shoulders are curved forward. But it tends to be exacerbated in breast cancer patients who have had mastectomies. As I tell the patients, you just had surgery on your chest. You don't want to accidentally bump into anything and cause a ton of pain. So you walk around hunched over like this, and you get kind of used to it. So sometimes weighted vests or different vests or different things to kind of trigger your mind about sitting up, standing up straight, and having your shoulders back can be very helpful in changing your posture and your body mechanics. I apologize, my camera keeps falling. It can help change your posture and your mechanics, and that also can help a lot with shoulder pain and chest pain after surgery in that area.
We have so many great questions. One on supplements. Are there certain supplements that you guys recommend or maybe discourage at certain times for neuropathy? Especially the question was on alpha lipoic acid.
Yeah, alpha lipoic acid has had a lot of studies that show that it might be a little bit helpful. And there's definitely studies out there that show dosing recommendations as well. The nice thing about alpha lipoic acid is it doesn't interfere with any of the other chemotherapies or treatments. I could be wrong, but as far as I have found, it doesn't interact with anything, so that also makes it nice and safe. I will say what we say in medicine anecdotally. So based on patient feedback, I haven't had a ton of patients say that they noticed a big difference with the alpha lipoic acid. I am not. I always mention it to my patients, especially if they voice interest in taking supplements. But I am not super convinced that it's going to make a huge difference. What I tell my patients is that you buy a bottle and you take it for a month because it's not going to change. It's not going to make your neuropathy better overnight. But if you finish that bottle and you haven't noticed a difference, then don't buy another bottle. I have seen a little bit better improvement in patients that take vitamin B6 or vitamin B12, which can be helpful in nerve health. It's usually, again, it usually doesn't interfere with any of the other treatments and can be helpful in decreasing your symptoms. Because it's two different pills right there, B6 and B12, I am practical and lazy, so I tell people to just take a vitamin B complex. It has other vitamin Bs in there, but it has the 6 and the 12 that you would want, and then you just have to take one pill. There has been some studies that show that it helps, and I will say this one, anecdotally, I do feel like more patients say that they've noticed a bit of a difference with the vitamin B complex.
And so the follow-up question is, these are safe for patients who have been through cancer treatment?
It is safe. Definitely, I always, it's a very generalized statement. Definitely check with your oncologist if you're still getting active treatment. If you're done with treatment, then it should be fine. You can check with your PCP. There's no alpha lipoic acid. We don't check levels in the blood, but with B6 and B12 we can. So if you're ever nervous that you're getting too much of it, one of your physicians can check a B6 or a B12 level real easily. If you want to know if you're low beforehand, I have definitely had some patients where they're low on B6 or B12, and not probably, but most commonly, they've had a lot of nausea and vomiting and weight loss. And so they're not eating like they normally do. And they get a what I call a vitamin deficiency. So their B6 or their B12 or one of the other vitamins that's also helpful in nerve health are just low because they've had this weight loss and they've had this poor appetite. So sometimes I will also check what I call nutritional labs for vitamin deficiency. And if it's low, then I have people supplement appropriately. If it's normal, then we just have a discussion about whether or not the supplements are something that they want to pursue.
Really great question about fatigue, and we really haven't touched much on that. But how do you guide patients to push safely past that initial fatigue to benefit from exercise, especially when patients have low blood counts?
Mm-hmm. Yeah, so it's really difficult with the low blood count, and I would say there's no great answer for that because you're just going to feel crummy if your blood count's low. But when it's on the higher end of everything, just trying to make sure that you stay mobile and as active as possible. And I am very realistic that sometimes staying active means that just getting up and walking around the house a couple times a day, because that might be more than you're doing currently. I actually had one patient where his exercise plan was to get up and walk to the kitchen to get some water or get a snack at the end of every TV show that he watched, because he just watched TV all day long. So like every hour he'd have to get up and walk to the kitchen and back. And he was able to build up his strength and endurance. Fatigue in cancer patients is so complicated, unfortunately. It's not just the blood count. It's the medications that you might be taking that make you sleepy and drowsy. It's the muscle weakness that you have. It might be the cancer itself that makes you fatigued. It's the poor sleep that you might be getting at night. It could be honestly some depression or some depressed mood because of everything that you're going through. So it's also with fatigue, it's asking all the questions and figuring out what if not all of those things that are contributing to the fatigue and how to address those different items.
How about prevention? What do you recommend for patients who have been through cancer treatment and want to be as active as they can to hopefully offset a secondary or recurrence? And especially the question was in colon cancer cases. We've seen a rise in younger adults with colon cancer. So can you talk a little bit about prevention?
That is actually a great question. It's a lot of it, and I know I keep going to exercise, but a lot of it is staying active and getting exercise. There is a study that should still be going on in Canada, but should be wrapping up. And they were doing it they're following colon cancer survivors over a decade, and seeing how much exercise they get and the recurrence rate. Because it hasn't been followed for that length of period before, but it has been shown to help prevent colon cancer in general that exercise and a healthy body weight helps decrease your risk of that. Obviously, there's some differences in the type of cancer you may have had and some genetic variances, but trying to stay active. And again, I did mention I don't like to exercise, so I'm very realistic that a lot of you may not like to exercise, but it's so healthy and helpful. So figuring out what is least appalling and what you might be able to do and starting off slow, even if it's just going to the gym once a week or whatever, but slowly ramping it up and not being hard on yourself that you may have a setback or you may not be as active as you want to be. I have a lot of patients who for various reasons, they can't get up and walk. And so I talked to them about doing seated exercise programs. There's a lot of stuff on YouTube where you can do seated exercise programs. There's a show on PBS called Sit and Be Fit, and it's all arm and leg exercises from a chair position. One of my old colleagues, she had breast cancer. She told me about the lazy ballerina on YouTube. And so it's all different dance moves, again, from a seated position. So there's different ways to get the activity in, understanding your own limitations.
Is there a number of minutes we're looking for exercise?
There is, it's a little bit different based on your cancer history, but the American College of Sports Medicine has actually recommendations. They had a roundtable paper a couple times now that talk about the different minutes that is recommended for each type of cancer type, both aerobic and strength training. So if you want to, there is an online reference for that because it's a little bit variable for certain types of cancers. The general population, it's recommended to have 150 minutes of moderate intensity aerobic activity a week, and then strength training 3 times a week. So again, it might vary from that a little bit depending on what type of cancer you had, but moderate intensity activity is how, the way I explain it is, you're doing something hard or fast enough where your heart's beating faster and you're a little bit short of breath, but you could still hold a conversation with someone if you were, say, walking on the treadmill next to a friend. You're not huffing and puffing and out of breath, but your heart's beating faster, you're breathing a little bit harder.
Okay, so as we're getting close to the end of our time together, I'll ask you, Dr. Barker, to walk through how often does a patient usually come to PM&R? You know, how long is their treatment? Where are the PM&R locations? All those good things. How do folks get a referral if they feel like they need one? Could you touch on those?
Yep. So it depends on what you are seeing us for, how often you see us. I will say probably the lymphedema patients I don't see quite as often. I might see a little bit more often at the beginning until we got a good regimen going. And then sometimes I see you maybe once a year, honestly. Some of the pain patients I see more frequently up front. And then if we get the pain controlled or resolved, then sometimes I don't see you ever again. So it's quite variable. So myself and Dr. Fadu are the main cancer rehab doctors, and we are at the cancer center. I have a lot of other colleagues who know how to take care of cancer patients as well, and they may have different what I call subspecialties, but different focuses within PM&R. So they might do more procedures or injections. You may have more, when I say higher level aspirations that I can't that I am not the best at. Like say you want to go back to playing a specific sport, and I'm not sports medicine trained, but I send you to one of my sports medicine colleagues who can tell you how to get back to playing basketball or skiing or whatever your goal is. So sometimes I refer out. There's a lot of general PM&R clinics around the main campus, as well as Las Colinas, Frisco, the Richardson site have PM&R clinics there. I'm sorry, I'm being very tangential. A lot of my colleagues do spine injections and see patients for spine pain, either from the cancer itself or during treatment, your sciatica has flared up, and so it's really bothering you. So again, a lot of different ways that we can help you. Physical therapy wise, we have physical therapy at a few different locations on main campus. We have it in the cancer center, but a few other places too. We have physical therapy at the Richardson site as well, and one lone physical therapist at Las Colinas that does a lot more sports stuff. But I'm also happy to, well, I shouldn't say, I guess not happy. If you need to refer to a physical therapy location outside of UT Southwestern, I'm happy to do that. If that's what's easier for you, I'd rather you get the treatment that you need rather than being picky and saying you can only come to UT Southwestern. To get a referral, I know any of your physicians can refer to PM&R. I want to say you might be able to do a self-referral as well. But I don't take my word for that. I feel like I have some people that have done self-referrals, but I'm not positive. So I can always check and let you know. But I know any of your physicians, your primary care provider even can make a referral. I've had dentists, and I think I've had a podiatrist make a referral as well. So any kind of healthcare provider can do that.
Well, we are right at 1 o'clock, Dr. Barker. Thank you for the rapid fire Q&A at the end. Lots of appreciation in the chat for the good information today. And just a reminder that you will receive that recording Monday or Tuesday next week, so you can reference back some of these good things. Thank you so much, Dr. Barker. We hope you will continue to join us for our Lunch and Learn series next month. And I'm sure you'll get some information on that as we go forward. So I hope you all have a wonderful weekend.
Thank you.